Okay, good morning all of you. Last lecture I have started talking about visual acuity and the principles of visual acuity. In this lecture, it is an extension of the last lecture. We will talk about visual acuity assessment in children. Why visual acuity of assessment in children? We are taking another class because visual acuity is much easy when we are taking the visual acuity for literate adults. Visual acuity is little bit difficult when we are assessing the visual acuity for illiterates because there are different charts for illiterates or patients who cannot read and write. But visual acuity is very tough when we are doing this visual acuity assessment for children. Why and how, that I will discuss in this module and this lecture. Okay. The first of all thing which we have already discussed, visual acuity is an estimation of spatial resolution ability. Only a part of visual function, minimum distinguishable acuity, uh, minimum separable acuity, minimum recognizable or legible acuity. We have already discussed about it. Here you can see why we should record what I was telling in the first slide, but why we should record visual acuity in children. What is the importance? Why it is important? The most important reason of taking of visual acuity is it is useful in decision making because very small children cannot say that whether they have problem in their eyes or not. And if there is a problem in their eyes, if we do the checking of the eyes or the evaluation of the eyes properly, then we can detect the problem early. We can detect the problem early. We can detect the problem. If we detect the problem, we can start the treatment early, and the prognosis chance is very high. And the problem if solved, there will be no permanent damage. The more we delay, the more problems happens, more complication starts, and the prognosis of getting a visual acuity for the children for the development hampers. That means, as you all know, the cognitive development of the children happens most in the brain, mostly in the early years. And if the vision does not reach to the brain, the cognitive development will not happen. So the visual development will not be normal if the visual acuity is not there, if there is any disease or if there is any ophthalmic condition. So to know that whether there is any ophthalmic condition, whether there is any pathological condition, or whether there is any physiological anomaly, or whether there is any infection, inflammation, whatever it is, we need to find it out. And the most probable indicator for finding if there is any problem or not is our visual acuity. So if we can find out what is the problem of the visual acuity, what is why the visual acuity is less in children, then what we can do is we can easily check the visual acuity if there is any problem. If there is no problem, then we can understand. So visual acuity in children is very important, very much required, and very much important indicator for finding out if there is any problem or not. I think this is clear to all of you. Next is, let's start with the history. As I told you in the last lecture, the most common chart is Snellen chart, and it was introduced in 1862. In 1903, American Ophthalmic Society established the use of capital letters. In mid 1950s, with the establishment of the Allen's card, development of pediatric vision testing were reported. So with the start of Allen's card, which we will show you how it is done. So pediatric visual acuity and visual acuity for children were reported. Age group, in which age group we do this visual acuity. So before going to the visual acuity assessment for pediatrics, we should know the age group, in which age group we can divide the children into different goings. Infants we normally say as birth to 14 months, we called it as infants. Toddlers we can call 14 months to 2.5 years, it is normally known as toddlers. Preschool is 2.5 years to 5 years, it is known as preschool. School going children is from 5 years to 15 years, is normally known as school going children. So these are the age groups which is normally known as where we can say that the children can be divided: birth to 14 months, 14 months to 2.5 years, 2.5 years to 5 years, 5 years to 15 years. So if we can divide the age group and the children in these age groups, then only we can find out. So birth is normal visual acuity for the birth is, you can see here, 6 by 300, that is 20 by 200. Normally in one month the vision improves to 6 by 200 to 6 by 90. In the another half the visual acuity goes to 20 by 667. In next 3 months the visual acuity goes to 6 by 90 to 6 by 60. That is 20 by 300 to 20 by 200. In the next 6 months, the next 3 months, that is 6 months, we normally goes to 636 to 630, that is 20 by 120 to 20 by 100. In 9 months the visual acuity go to 6 by 24, that is 20 by 80. In 1 year it goes to 6 by 80, 20 by 60. In 18 months the normal visual acuity comes to 6 by 12, that is 20 by 40. In 2 years is 6 by 12 to 6 by 9, that is 20 by 40 to 20 by 30. And in 3 years it goes to 6 by 9 to 6 by 6 singles, 20 by 30 to 20 by 20. And in 4 years the visual acuity goes from 6 by 9 to 6 by 6 crowded. So you can see here from the birth visual starts developing, and in 4 years you get fully 6 by 6, 4 to 5 years. During this period in the chart, as you can see, if there is any pathology occurring, or if there is any eye problem occurring and you are not treating it, you are not evaluating it, then the total development, this development of this vision, normal vision from 6 by 6 300 to 6 by 6 will get hampered, and the children will be developed visually handicapped. Okay, so it is very important to evaluate. Until and unless you don't do the evaluation, you will not be able to find where is the problem. And if you can find where is the problem, then only you will be able to diagnose the problem, then only you will be able to treat the problem, then only you will be able to do proper diagnosis of the patients. Okay, so in 5 years it is 6 by 6 to see. So from day one what we normally do is, we first try to understand whether the vision is developing or not. We can do the whistling, we can eye contacting of the patient with the mother. We will see whether the child is responding to his mother's eyes, or whether the child is looking at mother's eyes or not. If the child is looking at it, then everything is normal, and we try to find out whether the child is looking at it, whether listening to the voice or not. Okay, so day one we need to check this. Communication, at 8 weeks we need to check the communication, whether he is listening or whether he is responding to the sound whistling, whether he is looking here and there whenever there is a sound or not, or whether he is responding to the visual stimulus if anything is there, whether they are looking at it. All these things are very important at a very small age, that is at the 8 weeks. Until and unless the child is not doing that, he will not be able to know whether the child is in the right frame. In 12 weeks you can see the child is smiling, so he can understand the face. You can understand, if he can see someone smiling, he is responding with a smile. That means he can understand the face, he can understand the surrounding. If somebody is scolding or making face, he starts crying. So you can understand the emotional connect which the child is having. The child can connect with that, and that is very important. That can also tell us how much the child is visually uh, responding to it, and what are the main needs of the patient. After that you have to check whether the child is fixating and following the light or not. If the child is properly fixating and following, then you can understand that the vision development is proper. In the next step we have to check whether the child is properly fixating the light and following the light, and that is very important. That is one of the most important thing of visual acuity, is whether the child is fixating and following or not. After that, method of testing visual acuity in infants. In infant, we check once fixation and following is there. Suppose we are putting a light like this and we are moving the light here and there, and you have to check whether the child eye is moving or not. Once it is there, then we have to check whether the fixation is maintained. Means when you are putting the light like this, the child is also looking at the light continuously. So fixation is maintaining. Fixation preference, which fixation the child is doing, that also we have to check. If the fixation is preference, then also it's okay. Then we have to check the optokinetic nystagmus. What is optokinetic nystagmus? That we will come. Force choice preferential looking test, that also we will discuss, and visually evoke potential. So all these tests are very much important. If we can tell all these tests, then only we will able to understand whether the child is having any problem or not. Until and unless we don't do that, we will not be able to understand. So fixation maintenance, how we check the fixation maintenance? There are two types of fixation, centric and eccentric. Now what is centric and eccentric? I will explain this. Now centric fixation, whenever a child is looking centered to the light, okay, with his fovea and the macula and the eye is fixating over there, that is known as centric fixation. Whenever the child is looking through the eccentric way, well, like this, not the center but through the peripheral part, that is known as eccentric fixation. Understood? So whenever a child is looking at the center, you can center of the fovea and the macula, you can call it centric. Whenever the child is looking through the peripheral, you can call it eccentric fixation, that is known as eccentricity. Components of fixation: central, steady and maintained. We normally write CSM in our clinical papers. CSM means whether whether it's central, it's steady and it is maintaining or not. So we write it CSM positive, CSM negative. Fixation preference, how we check? Place a 10 diopter base down prism in front of the eye. We put a 10 diopter base down prism in front of the eye. Alternate fixation, we close this eye, we close this eye, we close this eye, we close this eye. If fixation does not maintain, then the preferred eye is occluded. If the fixation is not maintained, then we can call the preferred eye, which we called it is occluded. If the fixation is maintained through a blink, then also visual acuity is good. If the fixation is maintained and with a blink, after blinking the fixation is maintained, then the visual acuity is very good and there is no problem. This is how we check the fixation maintained. Okay, fixation preference, sorry. Next is optokinetic nystagmus. Optokinetic nystagmus is a physiological test. Okay, and this test is normally in there with every patient. Whenever a patient is nystagmus, what is nystagmus? Whenever our eyes is moving here and there, we call it nystagmus, right? And this nystagmus is optokinetic nystagmus is a normal physiologic thing. And to examine whether our eyes is in a normal position or not, we need to do the optokinetic nystagmus. I will give you an example of optokinetic nystagmus in. Whenever you are traveling in a train, just look at the passengers sitting opposite to you, looking outside the train, and suddenly another train is passing by. You will see the patients of the eye. You will see the patient's eyes continuously moving like this. That is called physiologic nystagmus. It is also known as optokinetic. So any moving thing, whenever we see, our eyes, to make the fixation steady, our eyes starts moving like that. So that is known as optokinetic nystagmus. The same nystagmus we try to check for the children. So whenever we try to check this nystagmus for the children, we put a drum like this, which you can see in the screen, red and white, red and white, red and white in front of the patient's eye, and we continuously move that drum. So whenever we continuously move that drum in front of the eye, we need to check whether the children's eye is moving also along with the drum or not. If the patient's eye is moving, has to follow the fixation patient's eye, and if it is moving like a moving train, then only you will understand that visual component in the eye or the eye's functional visual acuity is there and the eye is normal. Preferential looking test. Now what we do in preferential looking, this is another very interesting test, I will say. Infants prefer to fixate high contrast bolt to low contrast bolt. You can see here one eye is patched, here one stripe is there, here another stripe is there. You change the stripe from here to here and here to here, and you check whether the patient is changing his eye from here to there and there to here. If the child is continuously changing, that means the your patient's visual acuity is normal, and slowly you change the contrast of this two chart. So if it is done, then we called it forced choice preferential looking test. Infants prefer to fixate high contrast bold strips rather than homogeneous field. Two targets and a central fixation light at infant's eye level. Examiner has to become familiar with child's looking style. First fixation, duration of the fixation, and facial expression of the patient. So whenever you are looking at the facial expression of the patient, to understand whether the fixation is changing or not. If it is there, then the patient's eye is absolutely normal. VEP, another thing which is normally done, it's an objective way of checking the visual acuity. So here, although it's not so comfortable for the patients, we place electrodes on different occipital lobe of the patient, and checkerboard pattern is shown in the screen. You can see at a rate of 6 cycle per second in front of the eye of the patient's eye, and the electrode placed on the skull. Result is compared with the VEP of adult. So normally the checkerboard is changed slowly, and we need to check whether the child is looking at the checkerboard change or not. And the graph which we get, we normally compare it with adult. It is not so comfortable. Only we do the for the child who do not respond to the other test which I have told you, optokinetic nystagmus and preferential looking test. Now in the next section, we will discuss about methods of testing visual acuity in toddlers. Toddlers means those who can little bit. Now we were talking about absolutely infants. Now the child has grown up. Now he or she is in the toddler group. So in the toddler group, we will talk about visual acuity for the children who have started walking. So there are few tests which is known as 100,000 sweet test, Cardiff acuity test, and dot visual acuity test. In this type of test, we normally play games with the patients and little bit of letters, so that the patients are able to respond to those letters and the games, so that they will be able to understand. Here you can see a very sweet test. If child able to pick up small sweets at 33 centimeter, visual acuity is 6 by 24 to 20 by 80. So you have to show some sweets like this. You can see in the palm, and the child, you have to ask the child to pick up the sweets. If the child can pick up the sweet, then you can tell that the child visual acuity is absolutely normal. Okay, so these are all games, and if he can pick up from 33 centimeter, you can tell that the child visual acuity is 6 by 24 or 20 by 80. Okay, so this is one test. Another is Cardiff acuity test. Again, this is a very interesting test. Normally you give this type of picture in front of the patient, and you slowly move the picture here and there, and you ask the patient whether they can see the vanishing target or not. The principle of the target design is that of vanishing optotype. Suddenly it will be there, and you will move it, and you will keep it like this here and here, and you will check whether the child is looking at that target or not. Targets or pictures are drawn with a whiteboard by two black bands, all on a neutral ground. The children examiner simply observe the child fixation. So once the child fixation is checked, you can check that the child can see, and then only you will able to understand. So that is known as Cardiff acuity test. Okay. So this is Cardiff acuity test. Next is, so you can see here, this is how we measure the Cardiff acuity test. B is first is given plane. If the patient can read, we can call it Snellen fraction 20 by 60 or 6 by 36. C teacup, if the patient can understand, it's 20 by 127 or 6 by 76. D is hanger, if the patient can read, it's 0.7, 20 by 100, it's 6 by 60. E is clock, if the patient can read, it's 0.6, 20 by 80, 6 by 48. F is phone, if the patient can read, it's 0.5, 60 by 20 by 63, 6 by 38. G is scissor, 0.4, 20 by 50 and 6 by 30. H is glass, 0.3, 20 by 40, 6 by 24. I is ball, 0.2, 20 by 30 and 6 by 19. J is plane, 0.1, 20 by 25 and 6 by 15. K is hanger, 0, 20 by 20, 6 by 12. And L is scissor. If the patient can read, then 6 by 9. So accordingly, this is accordingly we check the children's visual acuity through them. Next one is dot visual acuity. There is a black dot on a white background, and we closely change this white background dot in various ways. If the patient touch the black dot, and he has to touch the black dot where it is, test distance is 25. If the patient can touch it, then we consider as 20 by 800. Okay, or 20 by 20. Administration of test in preschool. Now we come to the preschool. We have done with the infants, we have done with the toddlers. Now we will do with the preschool, means before the child is going to the school. Now he can see little bit more and how to do it. A pre-test to teach and check the children's reliability in responding to the test. First we have to teach the students to check, and we have to check whether the responding of the test is reliable or not. A test to assure that child response are reliable at 10 feet. from 10 feet whether child response is reliable or not. Actual measurement of acuity level at 10 feet. From 10 feet whether the acuity level is measured or not. Means from 3 feet whether you can measure or not. Methods of testing visual acuity in preschool says Lee symbol chart, lighthouse flash and card testing, Allen's picture card, broken wheel test, tumbling eat chart, landlord C chart, surgeon's hand test, and HOTB test. So these are the tests we need to do to find out whether the visual acuity in preschools patients can see or read the letters or not. So Lee symbol test, you can see the task is to match and point out the distance target. 10 feet distance, we need to check pictures, circle, square, house and apple. These are the Lee symbol test. Lee symbols means we have got different types of symbols in the patients, and we normally need to put a patch in the eyes, and we have got a card in front of the patients where the patient can see the similar type of mark is over there, and over there you have to just mark which one the patient can see. If the patient can see that, then we can say that that is there. So there are different types: circle, square, house, apple. So whether there is a circle, whether there is a square, whether there is a house, there is an apple, all these things you will be able to understand. So if you can see all those things, then only you can understand whether the patient, how much the visual acuity is there, then only the patient will able to understand. Next is lighthouse card test. In lighthouse flashcard testing, 12 cards are available. Size of each card is 4 into 5 inch. These cards have their types of picture target. Target size available from 20 by 200 to 20 by 10. In 20 by 200 card, we have 20 by 100 target size on the reverse size. So all this card, you will show it at different level, and all these 12 cards the patient needs to identify. If the patient is able to identify all these cards, then the patient visual acuity is absolutely normal. Next, which was the first, is the Allen's broken picture card. Here 6 pictures are there, and in these 6 pictures, horse, bird, cake, hand, car, telephone, you have to check it with the card size of 4 by 4 inch with white background, and you have to check whether this 4 card size is available or not. 4 by 4, if the patient it is there, then you have to mark it. A patient will identify it, and if the patient can identify, then the visual acuity is fine. Next is the broken wheel test. Broken wheel test, patients again have to understand. In the 2 pictures you can see which one is broken, patient has to identify. If the patient can identify that this wheel is broken, then it's good. Here cards are presented with picture of a card very familiar to the child. 2 cards are held before the child. He simply has to recognize which one is broken. So if he can recognize which one is broken, then this chart can be easily recognizable as one of the visual acuity. So the card will get smaller and the patient has to identify. It consists of 8 pair of test cards and a sample pair of card 20 by 20 equivalent to the test. Next is the normal. Now we are coming slowly towards the normal chart. Is the tumbling E test. Patient has to teach which is the E and which side the E is, and the patient has to recognize where the E is, in which side the E is. If the patient can identify which side the E is, then the visual acuity is normal. Okay, so we have to identify where the E is and which side the E is. If we can tell, if the patient can tell, then only we can tell them patients which side of the E is there. The child has to detect the orientation of the limbs. Simmons use 3 direction to avoid confusion. So we have to understand where the E is and how the E is, in which side the E is there. Landlord C test, in the similar direction we have to find out where the C is broken or where the we can see the C properly. If we can see the C properly, in which direction it is open, then we can understand the landlord C test. Similarly, in the surgeon hand test, we have to find out in which direction the fingers are open. If we can identify, then we can see the test. Again, HOTB test, optotypes are used to avoid left-right confusion, and the child has to identify the letters of optotype T, V, O, H, and we have to mark which letter, where the letters are. So where we can see the letters, and if you can mark over there, then we can identify where the letters are, and as a result we will able to identify where the child has to, how much the child visual acuity is all about. So these are the methods of testing visual acuity in school going children, which I have already discussed. That is the tumbling E test, then landlord C test, then we have got surgeon's hand chart test, Snellen's chart, Logmar chart. All these charts are there. So once we can do all these tests. We can do Snellen chart. I already told you there are several different size letter. One large letter is there where one letter of largest size number, and each letter size increases, letter size level increases, no logarithmic progression, slowly the size of the letters goes down, and we have to find out which letter is there, and accordingly the letter we can find out where the number is. So 6 by 60, 6 by 36, 6 by 24, 6 by 18, 6 by 12, 6 by 9, 6 by 6. So we can identify where the letters are, and we can find out which the letter is. Similarly, in logarithmic, I told you in the last lecture only that logarithmic, each letter, each line is having five letters, 5, and each letter's size and the distance between the letters is different. And we need to find out where the letter size is, distance between the rows and the letter size, and we need to find out the legibility. Okay, so good legible at opto size at each level, and it is very accurate test compared to the Snellen chart, because in Snellen test there was no legibility there. There can be a lot of problem over there in Snellen chart, because in Snellen chart the numbers of letter in each line was not there, equal spacing was not there, equal spacing between rows and letters was not there, but here it is there. So you can find out that in Logmar chart is much better than the Snellen chart. Now evaluation of binocular vision. Now apart from visual acuity in a children, we also need to check the visual acuity, binocular vision. Why we need to check the binocular vision? Because most of the squint and other problems starts at the very small age. So binocular vision of children has been greatly affected in presence of strabismus. So if there is any strabismus or a squint, we can understand that there can be a lot of problem. Direction, frequency, magnitude, laterality, AC by A ratio, and cosmesis all is there, and we have to find it out. Sequence of testing for binocular alignment: observation, observation test, we have to check the observation whether there is any squint or not. Hirschberg test we have to do. We will teach you what is Hirschberg test in binocular vision function test. Krimsky test is there, and Bachner test is there. All these tests I will tell you where we need, and cover test is obviously there. So observation, the optometrist should be looking for obvious stimulus, whether there is a pseudo squint or whether there is a pseudo esotropia, pseudo exotropia. It is very important, because most of the squint, what happens, we think that there is a squint, but actually there is no squint. Okay, so we need to find out whether there is really a squint or whether there is no squint. The observation is very important. Next is Hirschberg test. We have to put a light at 50 centimeter, and we have to check whether the light is falling on the center of the pupil or not. Here see, there is a squint, so the light is not falling on the center of the pupil. If it is falling on the center of the pupil, then there is no squint. If it is falling outside or periphery, accordingly we can do. This is a rough test to find out whether there is any squint or not. Krimsky's test, again we have to put prism in front of the eye, helpful for estimating the magnitude of infant strabismus, cause of poor vision. So Bachner test, again we have to illuminate infant's eye, both eyes with direct ophthalmoscope in front of the eye. By comparing the reflex, examiner can evaluate binocular alignment. Direct cover test, also the cover test we need to do cover uncover test, and direct cover test, cover uncover test, and alternate cover test. All these tests are done to check whether there is a squint or not, whether there is any hidden squint or not, or whether there is any alternate squint or not. So all this is a very simple test. Covering one eyes, we need to check the movement of the other eyes, or alternating covering the two eyes, we need to find out whether there is any alternate problem or not. But this is a very important test to find out where the problem is of the squint. So environment adjustment. So for children, you need to do the environment adjustment very well. Otherwise, the children will get may get angry or start crying. Okay, make it puzzles. So you need to keep small chairs, toys, games, puzzles, scheduling appointment, children's daily rhythm. Okay, small but meaningful changes needs to be done so that the children feel comfortable in your clinic, don't feel scared and run away from your clinic. Normal wallpapers, familiar cartoon, like this type of cartoons you can give, so the children can feel that, oh, they have come to a good place where their eyes will be and they don't get feared. Until and unless you don't make the thing comfortable, you will not be able to do. So that's it from my side of visual acuity measurement for children. Okay, thank you so much.